Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we bring the bright light of science to the darkness of current EMS clinical practice. Y'all, I am so excited to bring you this episode. I plugged the ESO PCRF research forum in the last episode pretty hard because I knew I was headed to a forum in Austin the next week. I might have even mentioned bribing Dr. Crowe with tacos to come on the pod and explain the statistical process of imputation. Well, I got her to do that and way more. As it turns out, she and her colleagues just published a paper using the ESO dataset to examine the association between patient race and whether they receive pain medication. And boy, does it seem like people have some thoughts on this paper. Now, as it turns out, that paper involved using multiple imputation. And, I sort of thought it would be a great opportunity to discuss this statistical process. And that's really what I was focused on. And then I read the comments on an article Remle wrote about this paper with her co-author, Dr. Jamie Kennel. I felt like there was a profound misunderstanding about what this paper found and what the implications of it were. And I wanted to give Remle an opportunity to go into a bit more depth about it. And then after I showed up at ESO for the research forum, I discovered that Dr. Kennel was a fellow mentor. So the reason I'm so excited is that I got Remle and Jamie to join me along with OG Lighthouse Project co-host Mike Verkest to talk about this paper. Now, this is truly a fascinating discussion. I learned some things, and I think you will too. Now, I know that this can be a difficult discussion for all of us, but I think if you approach it with a desire to understand, you'll come away more informed. I know I did. So stick around. We will be right back from ESO Fascinating Discussion.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Hello, fellow nerds.
Hello,
my friends. We got Remle, we got Mikey. Everybody knows Remle and Mikey.
Do we?
Mm-hmm.
Jamie, welcome to the podcast. I think this is the first time we've had you on.
Upcoming star.
Yes, absolutely. Rising star. Actually, I would say star already. So Jamie, I'm going to have you introduce yourself, but bottom line is you are a paramedic, you're a professor, you're a PhD, you are a teacher, and you are, I'm going to have at least two of you get really mad here, an Oregonian. Did I get that?
Got it. That's
all
pretty
right. Not
good.
bad for somebody born in Oregon.
Yeah, exactly.
So what's your research expertise here?
Discrimination in EMS treatment.
So as in I am there on the scene and I am trying to discriminate between someone in VFib and someone in VTAC, right?
Totally not.
No?
No.
All right. Well, I tell you what, before we get into why you think differentiating VFib and VTAC is not important, tell me who you are, and then the two of y'all have a paper that we want to talk about. Who are you, Jamie?
Highlights. As Jarvis said, I'm from Portland. I'm a professor and a department chair between two universities, Oregon Health and Science University and Oregon Institute of Technology, where I oversee the EMS department, where we have EMT program, paramedic program, critical care, community care, bachelor's program, do some administration stuff, and do a bunch of research stuff in the discrimination around social variables within EMS. So race, obesity, gender, language status being a few of them.
Okay.
And your favorite kitchen appliance is the masticating juicer.
Important.
Oh, that was good.
Important.
You also have to be careful how you say that these days. But
Yes.
Indeed.
Yes.
So we are all together in person in a really cool place. This is the Saxon Pub room. This is one of the meeting rooms at ESO headquarters in Austin. Saxon Pub, for all of you not from Austin, is just a classic historical pub in Austin. So all of the conference rooms here at ESO are flavored, if you will, something about the local community. What room? We were in the Austin Beer Works room the last time.
No, we were in the Alamo Draft House.
Alamo Draft House. I'm sorry.
Which is a theater.
A theater.
It's a movie theater.
Yes.
There's also Kirby Lane Cafe. That's a great one. Kirby Lane is
We
a
almost
wonderful
recorded
place
in
here.
there. Yep.
Great place for breakfast. So Saxon Pub, we're here for the ESO PCRF Research Forum. I plugged the hell out of this in my last episode, and we're here now. We want to talk about a paper that y'all just got published in Annals. Tell me what this paper was, what you're looking for, and then hit us with the PICO question.
Sure. So I'll get started and let you add in.
Okay.
We know there have been quite a few papers looking at disparities in analgesia administration. But in the papers that have been out there, there have been some questions left about, oh, well, maybe it's not really a disparity. Maybe it's because of distance to the hospital and there was a difference there and that explains the disparity. Or maybe it's because patients refuse medications at different rates and there's not really a racial disparity. Or maybe it's because they were just drug seeking and they weren't actually experiencing pain. And that's why, we saw a disparity that wasn't real. So
that part, this is not my area of expertise, but that part right there kind of irritates me.
It irritates us as well, which is why we took on this paper. We set out to do a Mythbusters with data, if you will, and take out all of those what ifs and see, is there really a racial disparity?
And a big what if that Remle missed was socioeconomic status.
That's a huge
So there's
what
a
if.
lot of critique about, is this really race or is this SES?
Which also kind of irritates me because the implication. So I think y'all wrote a paper wrote an article for EMS1 about this paper.
We did.
And it was
No one commented on it, and no, it was totally fine.
and you
Our work is
just
done.
you discussed the findings in this paper, and you clearly hit a nerve. So I will go ahead and summarize the feelings. Is that this is the paper y'all wrote saying paramedics are racist.
Mm-hmm.
And the implication here is that maybe if we're treating different races differently, it's either because, well, black people seek drugs more often, or black people are way more poor and therefore seek drugs more often. So there's an implication there.
And just to add, the implication is also if you are on drugs, you are undeserving of pain meds.
Good point. Yeah. Okay. I know I've taken care of an awful lot of cancer patients, and you know what? They're on pain medicine. And despite that, they have the gall to tell me they're hurting.
How dare they?
Yeah. So what was your objective here? What were you trying to find out?
So we were looking to see if after controlling for all of these what ifs, if there really was any racial or ethnic bias. And so we went into this with an idea of, well, how can we come up with a clean population where we can really ask this question? And so we were able to isolate a group of patients from a national database where the patients were diagnosed upon ED arrival with a long bone fracture, which kind of takes out that what if, oh, they were just seeking pain medication. We can all objectively say breaking a long bone probably hurts.
Mm-hmm.
Yeah. They wanted those drugs so bad they broke their femur.
Yeah.
That's commitment to the cause.
Yeah.
Fair point. So you looked at ED diagnosis and your population of patients. Did you limit it by age? Is this adults only?
This is adults only. There's a separate paper in the works for pediatric patients, and spoiler alert, really similar findings.
So what's your definition of an adult here?
18 and up.
So you looked to get into the data set, and you're using the ESO data set, right?
Yes, that's
So the anonymous, essentially public release data set. Same one we've talked about before, and you were what was the year range? I'm sorry.
2019 to 2020, 2 years.
2
years
years,
of data.
2019, 2020. So really before COVID.
2020, so
So it's
COVID
the full
was March,
2020.
all of 2020.
Okay.
Yeah.
And these are adults with long bone fractures diagnosed with radiology in the emergency department. Okay,
Transported by EMS, primary
those are-
911 call, no interfacility.
no IFTs. So this is probably a group that we would agree If they say they're in pain, they have a good reason.
Yes.
Okay.
So that was the first thing that we set out to do is like, let's take a population where this won't be as controversial in terms of, well, maybe I should have withheld pain medication because of X, Y, or Z. You know, there's some of these myths out there about, well, it's abdominal pain. I don't want to erase the diagnostic pathway.
Oh,
we're not going
gosh.
to, yeah, we're
1988.
right. But we didn't want to deal with any of those things. So
Yeah.
we said, well, what's a really simple group we can isolate to? Okay, well, long bone fractures are one, pretty common, and two, pretty painful.
Okay. Now, if I can think of a reason that I have not given pain medication to patients with long bone fractures, they also have, say, a brain injury, they have respiratory depression, and their GCS is 4.
So that's a really good point. We isolated to patients with GCS of 14 and up.
Okay.
And these were isolated long bone fractures. So polysystem trauma and those things were removed.
Okay. So no other diagnoses. You have the ICD-10 codes. Those are all out. And they are alert, at least with the GCS of 14.
Yep. Throughout the whole call. So lowest GCS recorded had to be 14 or up.
All right. And all right, so then you are comparing two groups, right? So you're putting patients into buckets to look at the difference between them. What are your buckets? What are you comparing here?
More than two groups. So I'll let you talk about
Multiple
how we
buckets.
classify
You have-
race and ethnicity.
You have polybucketemia?
We have polybucketemia.
Okay.
Turns out you can't just lump people. You try to put them in their right groups.
Okay.
Yeah, so the primary buckets that we put them into were by patient race.
Okay.
And this is a little bit of a messy one. It's recorded in the chart by the EMS provider. So our belief is that it's the perception of the patient's race, and the patient wasn't often consulted on that. Our feeling is that that's a much more valid measure to measure the perception of race, because we think that's the perception that is influencing the provider.
Okay.
Right?
All right.
There's a
So
lot-
And not
there's a lot
to
of
infer
critique around it.
nefarious intent either.
Sure.
But, you know, we all take shortcuts in our brains. It's what's kept us alive and survival. So
right.
realizing that what I see is probably going to affect my implicit bias or those shortcuts in my brain more than if you tell me, well, you know, I'm a quarter Native American and I'm this
Right.
and this and this. Well, you probably don't look at me and see that.
I'm sorry. I was just thinking you got 4 quarters each with a different race and throw in an ethnicity. I'm like, I have 2 fields. What am I going to put in these fields?
But so to Jamie's point, we're measuring a social construct rather than some biological mechanism. We don't have a reason to think with analgesia that there's a biological mechanism at play. This is a social construct.
I don't know. Some of the comments I read on that EMS1 article.
Well, there's some survey data from, it was a group of medical students where there are still a lot of false beliefs about biological mechanisms and pain pathways, but that wasn't what we set out to look at here. We were just looking at was an analgesic provided.
All right. So we're talking about our polybucketemia. What were your buckets again? What'd you
Our
end
race
up with?
buckets, so we've got a handful of buckets. The primary buckets are race, and the primary categories are Black, Hispanic, Asian, unknown, and other. I think Asian was actually a very small bucket, so it was
And white,
rolled into
non-Hispanic.
other, and then whites.
So I want to ask you this because I've had to work with this data set, had the pleasure of working with this data set. And
You have to say that I'm here.
because
I'm here too. Yeah.
considering where
And
I
you're
am,
closer.
I know. I'll whack them for you.
you collect race and ethnicity, and because of the way NMSIS defines these, sometimes they conflict with each other.
There's a little bit of duplication, and it's important. So there's actually some best practices around how to bucket and how to talk about race and ethnicity in medical research published by JAMA. And one of the things that they highly encourage is don't separate the person's ethnicity from their race. These need to be considered in collaboration because one human has those things. So I am white, non-Hispanic. You don't want to analyze me as white and then put non-Hispanic in a separate variable because that's not true to the experience. So we did a combination of all of these variables, and Hispanic is an interesting category because there we did include if you were white Hispanic, Black Hispanic, Asian Hispanic, whatever, because we're using Hispanic more as a potential proxy for there's a likelihood of a language barrier.
So you said you did use that. So if you have, because the way it's set up, you can have white Hispanic, Black Hispanic. If Hispanic was in there at all.
Then they went into the Hispanic group.
Got it.
But the other groups were one race non-Hispanic, so Black non-Hispanic, white non-Hispanic.
Got it.
And then because of sample size, now this is not an ideal thing by any means, but by sample size, we needed to collapse other and multiracial.
But Asian, even though it was a small, was still its own bucket.
It was not its own bucket.
No,
it was way
it
too
was
small.
in with other. Okay. All right. So those are your buckets. And then your outcome, what were you measuring? What were you looking for a difference with?
The primary outcome was the dichotomous variable of receiving a pain medication. So not looking at dose variation, not looking at timing, just the receipt of pain meds or no receipt of pain meds.
Any route, any dose, any pain medication.
Got it. So dichotomous, 2, yes, no, on, off. Did they get any medication versus not? And what did you define as a pain medication? How did you determine what a pain medication was?
So we went through the medication list that was available, that was administered in the time, and we picked out anything that could potentially be used for analgesia. So we're talking, in addition, obviously, to the opioids, we are looking at NSAIDs, acetaminophen, and that could have been an oral acetaminophen. So we cast a really wide net here, and obviously ketamine.
Did you do anything?
Yes. So we cast a broad net to give as much benefit of the doubt because we wanted to be mythbusters here. Okay, let's see if there's anything that might explain what we're seeing.
And you were looking for, so you calculated a proportion of these patients, Black patients that got pain medication versus white patients. And then did you have a referent you were comparing everybody to?
So in the descriptive analysis, we compared everybody separately, but when we did some modeling, because we wanted to adjust for that confounding, we did use white non-Hispanic patients as our referent for a multitude of reasons. One, it's the largest group to compare to, so from a statistical sense, it makes sense. And two, it was the group with the highest rate of analgesia.
Okay.
And it's a conventional way to do these models.
Right.
Yeah.
And I'll be Mr. Obvious. So the administration of a pain medication means that you were looking at ALS only.
So that was one of the inclusion criteria that we purposely did. Now, from a patient-centered perspective, that's not ideal, right? Because I don't order EMS and say, hi, I broke a hip and I would love a BLS ambulance, please.
Right.
Yeah.
So from a patient-centered perspective, not ideal. But with the goal of being Mythbusters, we decided to take all of the what-ifs off the table. So what if they were BLS only and couldn't administer pain medication? Out.
Right.
Not a problem.
Yeah. You bet. How did you make a distinction with your ketamine dosing? So if I gave you ketamine to intubate you, for example, versus, say, subdissociative ketamine.
So those patients would not be in our study if they got intubated. They had to have a GCS of 14, and I hope you're not intubating anybody who remains at a GCS of 14.
Yeah.
But you picked lowest. So even if they RSI'd them and then went to a 3, they would be excluded.
They would have been excluded, yes.
Fair point. Okay. All right. Well, I'll tell you what, I want to wallow around in methods a lot, but I think the general topic here is particularly after, I would much rather talk about the methods of this paper because—
I don't know that your listeners will stay tuned.
Well, that's one. Number 2, although I got some pretty listeners.
They probably
I mean, they're my people, but—
Yeah.
Number 2 is I think the concept here is way more important. So I did say on my last episode that we were going to talk about one pretty nerdy topic. We'll hit that topically and then get into the implications of the work here. So there was some data that was in here or some records of 911 calls where not all the data was available. So what was the most missingness? What variable, what field did you miss the most?
So if I asked you to guess, you'd guess wrong.
I would have gone with race, but having just looked at this, I think the data set has race on like 98% of people.
It's about 95, yeah.
Okay.
I wouldn't think male, female. Wow, it can't be this.
Something you do.
I was going to say pain scores.
It was pain scores.
Really? We've done pain score things before, and there's a crap ton of pain score data. Wow, okay. All right, so it's kind of hard. Well, did y'all have a cutoff on pain score? You get included if the pain score is above a certain point?
We stratified, but we didn't exclude.
Okay. So how do you deal with the patients that don't have any pain scores?
I wanted to delete them case-wise. However, reviewer number 2 had a different idea for me.
So you wanted to say, we don't have this data field. This is really important.
We just won't describe it. We'll describe it as a limitation. We don't know. We can analyze that population separately for did they or did they not receive pain, and we did do that. And we saw patients without a pain score were less likely to receive pain medication. And we can conjure up a lot of potential explanations. 1, they did not appear to be in pain, so I didn't take a pain score. Or 2, I never took a pain score, so I didn't know they were in pain.
Right. But we're just making shit up at that point, which is what you have to do when you don't know why the pain
score was missing.
Fair enough. So you wanted to remove it and then maybe do a sensitivity analysis, which you did. And did you have any differences in that group that didn't have pain scores versus those who
Not
did
from
use
the disparity perspective,
Okay.
but from the analgesia perspective, it was definitely
Sure.
that group was less likely to get analgesia, which we would expect.
But the primary thing you were looking at, disparities based on race, was no different. Okay. Which indicates that's probably not the driving
And
factor.
importantly, there was no disparity in terms of missingness in pain assessment. So that was
So
one
all
of
of
the
my
first
black
outcomes
patients,
that we looked at.
I'm just not recording a pain score.
That was not the case.
Not the
No,
case.
the missingness was
All
parallel
right.
there.
So reviewer number 2 apparently had just seen a paper about this new statistical tool. And he wanted you to use it, or she. What was the tool?
Yeah, and not so new. Yeah.
Yes, not so new.
It's new to me, which is actually, that's not true. I've just skipped over it. You know, I always advise people when you're reading through the methods, try to understand the groups that are being compared and does that make sense, and skip over any stats you don't understand. Well, now I've gotten to the point where I understand most of the other stuff, and this thing is left on my bucket of stuff I don't understand. So what is it? And just explain the concept to me.
So the kind suggestion from reviewer number 2 was you need to use multiple imputation
Okay.
so that you can use your full data set in your models, because it's inappropriate to exclude those people. You have to figure out a way to put them in your model. Use multiple imputation.
What they're saying is this is a big fancy statistical term that says you don't have the key value you need, so you need to put a value in there.
Yeah, you cannot just throw those people out. You need to figure out a way to use them in your model. And there is a statistical method called multiple imputation that allows you to have complete case analysis. And we can talk about how we get there. But there are some assumptions to that methodology that we didn't really satisfy in this paper. And so I pushed back a little, but
You kind of wanted, you were
I
done
really
with this
wanted
paper.
this to get out there. So it ultimately did not change our findings, which you'll see we present both the analysis with and without multiple
Yeah.
imputation.
A common way of appeasing a reviewer is, fine, we'll do a sensitivity analysis. So what you described then, I mean, I'm just an Aggie from East Texas. What I'm getting here is that you got missing data. There's no numbers here, so you're just making some stuff up. You're making data up. So
With an educated guess.
Yeah.
are you just making, so tell me about that. How,
that's what I
how
want
do
to
you
know.
do this?
So there's a couple of different ways, actually. So imputation is a broad procedure, and there's a couple of different ways. There's single imputation, where I use the available data that I have to create a prediction model of what I think that person's characteristic would be. So if I need to estimate their age, and I know their race, and I know I know which bone they broke, because the bones vary by age, which bone gets broken. Race, the age varies across the age groups. That kind of represents the composition of the United States. Okay, I can use all of these variables to predict what I think that person's age is. And that's single imputation. It just puts one value there.
So what I'm hearing, I'm sorry, I was a psychology major, and now I'm a stupid doctor when it comes to this. But what I'm hearing you discuss sounds a whole lot to me like regression.
It is regression.
Where it is. So you're trying to find a coefficient.
You're just
for
putting your
pain
outcome
value.
as what is the coefficient, and I'm taking my best guess at it. That's one way. That's single imputation.
Okay.
There's other ways where you use like average across the data set, and you just impute, well, the average age across the data set is
See,
this.
that's where I went, like just being a simple-minded fellow.
That is one method. There's some drawbacks to it, of course, because
It seems like
it's not likely to represent anybody.
Right.
The average human has what? Okay.
Yes, I'm sorry.
No, wait, I think we're on ODL. I can't talk about it.
So, but the other one, where you put your head in one place and your feet in the
Oh,
other,
well, if
what's
you
that
put
one?
your
That's
head
safe.
in the oven and your feet in the freezer, on average, you feel fine.
Yes. This is a medical podcast. I think I have repeated this at so many conferences, attributing it to you. So we're predominantly men here, but
In this room?
if we had one more woman, one less man, other than probably being better off, what would we have?
The average person in the room would then have one testicle.
And
One ovary.
one over, yeah. So I don't know of many people that have one testicle and one ovary. So yeah, that's what your averages are. Okay. So I'll tell you what, that's the concept behind
Somebody's sitting there calculating
imputation.
it.
You argued that the available techniques for imputation were inadequate for this data
Well,
set.
so
You
the
have
last method of imputation is multiple imputation, which is what this reviewer was advocating for. And essentially what that is you take multiple models. So you don't just impute one data set. Typically you do 10. 10 is a number where you sort of have diminishing returns. After 10, you're not going to get any better estimates. So they wanted me to do that prediction model across 10 data sets essentially and come up with a guess, which is what it is, best guess. It's an educated guess at that.
Right.
And then the model for multiple imputation takes those 10 data sets and it uses a Bayesian approach and it samples from the distribution of those 10 data sets. And it says, okay, here's your complete case regression analysis now that we've sampled from those 10 data sets where we took our best guess at the data.
Okay.
Which is okay, but it has some assumptions that underlie it. And the big one you probably already picked out is you have to be able to predict that missing value based on things that are in the data set.
Yeah.
And that is called missing at random, which doesn't sound like that should be the right term because it's not really missing at random. It's missing based on characteristics that you observed. But when you have data that are not missing at random, meaning they probably differed on something that wasn't in your data set, like pain score, I'm probably more likely to take a pain score on somebody who looks like they're in pain or has an injury with an angulated fracture or something like that. That's not going to get recorded in your EHR. So I don't think pain scores were missing based on things that I had in my data set. In that case, multiple imputation will never fix the bias. It's not going to work.
Interesting. Perfect. All right. I think we have satisfied the nerd quotient on the podcast.
And probably made reviewer number 2 very sad.
Well, you know, sometimes I've been reviewer number 2 and probably have asked for some stupid things. I am perfectly open to my home on the Dunning-Kruger curve. And when people tell me I'm an idiot, I'm like,
then you're not really on the Dunning-Kruger curve, are you?
fair point. Fair point.
I'm pretty sure
Use
that's
it as being unawares of that. Yeah.
So took the data set, excluded everybody under 18. You looked only for those people with ED diagnosis, confirmed, isolated long bone fracture, and
ALS unit.
And an ALS unit. They had the ability to presumably to give pain medication.
Alert throughout the EMS encounter.
Perfect. I like that. And then you put them into buckets based on the providers, the documenter's perception of their race. And you looked at the proportion who had something done for their pain versus not. And then you described whites had X%, blacks Y%, so on and so forth. And then you did some analysis to control for other factors and to look at, I'm assuming you came up with an odds ratio of blacks versus whites, Hispanics versus whites. What's your bottom line? What'd you find out?
But wait, there's more.
Oh, goody.
And then what did we do that you loved?
Yeah, so...
I don't know why Jamie's still my friend after this.
Hey, Jamie, what kind of phone you have?
iPhone.
You have an iPhone. What do you do your stats with?
You don't want to know.
What program
You don't want to know the
tool
answer
you
to
have?
this.
I don't think you're going to like it.
You're not going to
No?
like it.
What-
So
oh,
I-
God, it's something we can both agree on, right?
Yeah.
You're a SPSS, aren't
Yeah.
Yeah.
you? Okay, what kind of computer do you use?
MacBook Pro.
All right, and what kind of car do you drive? Oh, God, you're from Portland. It's got to be like a...
Prius.
Yeah, there you go.
So since I'm in Texas, I can say I have a 1-ton truck.
What kind?
GMC.
Okay, all right, see? So I think he's more on Team Jeff. He likes Chevrolets, he uses Macs, and he has an iPhone. What's the other thing that we...
I have dabbled in R and don't like it.
Ooh, I just
Oh.
love that about you.
Oh,
Yep.
Okay.
I also
All right.
feel strongly that the stats program does not matter. The understanding of stats is what matters.
yeah, but the problem is we all agree with that, so we're going to discard
just
that
wanna fight
and
about the
focus on the
program.
things we want to fight about. All right, so tell me what... Oh, I'm sorry. You were saying he did... There's more.
I roped Jamie into more.
Okay,
So-
what's the more?
So, and this may be jumping to the, I think there's 3 major takeaways, and this will elucidate the more option.
Ooh, I
Good
like that.
word.
I like
SAT
that. That
word.
was good.
Yeah. One is the findings found that in this national data set, it replicated the findings that were found previously in regional publications.
Okay, so we're essentially confirming things we've seen in other papers with different populations.
With the national data set.
And were those pre-hospital or were those hospital?
Yes,
Pre-hospital.
pre-hospital.
And do they also confirm, do we see something completely different in hospital?
No, negative. We
Okay.
do not. We do not. So we confirmed it, but there are some subtle differences that could be explored here. So we confirmed that if you were black, you were much less likely to receive pain meds than if you're white.
35% to be exact.
Wow. Okay.
There was not evidence to support if you were Hispanic, you received less pain meds.
I'm sorry.
There was no statistical difference
So they're essentially the same
Correct.
in your results.
in this,
In
data
this
set.
national
Yep.
data set. I've done previous work in our fair state where it showed a disparity for blacks, Hispanics, and Asians. I think significant finding 2 is that we also found socioeconomic variation in pain treatment independent of race. So
Let's come back to this.
okay.
What were your, because I want to talk about this because this is a good what if. What else did you find? So 35% less likely for blacks to receive pain meds
And
than
then
whites.
independent of your race, if you were encountered in a scene that was located within the lowest socioeconomic quartile in a variable that we use, the CDC's Social Vulnerability Index, then you were less likely to receive pain medication.
So she's not going to let me come back to that. She's going to jump on
she's
that
gonna
No,
right
we're
now.
gonna do
for
it.
now.
Okay.
Yeah,
All
we
right.
have to talk about it.
So said another way, if you're poor, you're less likely to receive pain meds than if
Yeah.
you're rich.
And we controlled for insurance status.
Well,
and it wasn't
it's only
a
these poor
binary.
black patients, right? Rich black patients got pain medicine.
Nope.
Negative.
No, that's not what
That's
you're saying.
not what we're saying.
Negative.
You said, because the key thing you said there was independent of race. So by itself, after controlling for race, socioeconomic status is an independent predictor of getting pain meds. All right. So what I'm hearing is that for whatever reason, if you are a minority, well, no, I'm sorry. If you are black, you are less likely to get pain medication. And if you are poor or more socially vulnerable, you're less likely to get pain medication.
Correct. And
Okay.
that poor status isn't a binary poor or rich. It's a graduated 4 options in
It's
the
a
data
quartile.
set.
Yep.
It's a quartile. And at each quartile, the odds reduce.
You saw a linear relationship.
That's right.
Or
Stepwise.
Stepwise. That's right.
All right.
So that's big takeaway 2. Happy to come back to that, explore it. Big takeaway 3 is some of the critique of prior work around racial disparities.
Oh, perhaps that you design this to address.
Partly.
Tell me what you got.
Methods to our madness.
Part of the critique to prior work and disparities was that a patient refused pain meds but was offered it.
Yeah.
And the charting of that is tricky because in our industry, the charting of refusals is an entire chart of care refused or not. And so
Despite the fact that we have a clear answer to how to document
We
this,
have a variable.
don't do it.
It is
That's right.
underused.
We
don't do it.
We
Okay.
don't do it.
So how did you tried to address this.
So we tried to address this, which was the painful part of this process, which I
see
think
what you
is
did there.
some of the reason
That was strong.
No analgesia was given.
No.
we got this published is that we looked at hundreds of narratives, I think thousands of narratives, 600 narratives per team member.
Yeah.
And so we read the narratives we read narratives of a large sample of folks that were not given pain meds,
Oh, I see where you're going with this.
right? And we looked for indications that they were not given pain meds, looking for things like they were offered and refused. Or we just missed it. They missed it in the flow chart, but it was captured in the narrative.
Nice.
And so we busted a myth because there was no difference, and largely there is some evidence to suggest white patients refused pain meds more often than black patients in the narrative.
So it
Based on
wasn't
the narrative
refusal.
review. Interesting. Okay.
And we had other buckets because there's another perception that, oh, well, maybe black patients had more contraindications. There was a reason why I couldn't give a pain medication.
I'm dying to find out what those contraindications are, but okay.
We did not find any of those.
Okay. All right. So 3 takeaways. Blacks received a pain medication 35% less often than whites.
After controlling for
After control-
socioeconomic status.
Oh.
For
Okay.
the same long bone fractures.
And you controlled for type of lung, which
Which
bone it
bone
was?
we
Okay.
controlled for pain score?
As a continuous variable? Or did you
Categorical.
We did it more than once. We did categorical, so none, mild,
Okay.
severe.
All right. Fascinating. And then y'all did not look at effectiveness, right?
That was not part of this.
Okay. So that's takeaway number 1. No difference for Hispanic or Asians or others.
No, I shouldn't say we didn't look at effectiveness. We looked at an end variable in a supplement around who arrived to the hospital still in severe pain. And obviously, patients who received an analgesic were far less likely to arrive at the hospital still in severe pain, which there's plenty of studies on whether these pain medications work. But patients who were not given a pain medication arrived at the hospital in severe
I'm
pain.
feeling things very darkly because this is one of my tips when I find people are given an awful lot of opiates and they're not working. It's kind of a diversion problem. So sorry, tangent.
Interesting. And so
Feeling
that was
dark.
another thing that we actually looked at in the narrative review was if there was any indication that, positioning or a different mechanism worked to relieve the patient's pain, we counted that also in a separate bucket on patient mentioned pain relief.
Splinting, ice,
Oh.
position, whatever.
Yeah, we looked
pillows.
so we had a bucket
did
for
all
pain
the
was
things.
relieved in the narrative. Yeah, this is the Mythbuster
right.
paper.
Yeah.
That's why some of those comments on EMS1 article
Yeah.
probably,
Almost as though they didn't read the paper.
it's almost as
Actually, almost as though they didn't read the article about the paper.
if, right.
All right. So number 1, less often. Number 2, socioeconomic status, independent predictor. And then number 3 is that you did a narrative review and identified that this difference is not due to disproportionate refusal rate.
Right, so no clinical or patient preference reasons could explain the disparity.
All right. That's the paper. Bottom line here, why? And this is really when you get to the EMS1 comments,
This is,
right?
It's uncomfortable.
Because this is a video podcast. Y'all can tell I'm a middle-aged white dude that's bald. And clearly, I'm going to say, you're calling me a racist.
And I think that's a common reaction,
Yeah.
and that's where we shut down a little bit on this conversation. And I would wager that most people are not overtly racist. However, we're products of our culture. Our brains create stereotypes and shortcuts, and stereotype activation is a lot more common in the setting of emergency medicine, where you're operating sometimes with limited information or partial information, and sometimes with time pressure. And so you put all these things together, and it's a perfect recipe to activate what we call implicit bias. And Jamie's the real sociologist among us and can probably dig a lot deeper and help us unpack some of these concepts.
Yeah, so I think there's 4 reasons the literature supports why this happens in medicine, not just in EMS. I think stereotype use is one of them through heuristics, and we operate in a clinically ambiguous
Professor.
ambiguous setting.
But do we know that we're doing that?
With time pressure.
Because I treat all my patients the same.
So
I'm colorblind.
let's hold on to this for a second.
Enough of you, Jarvis. Shut up. I'm making a point.
He's done with both of us.
One reason is stereotype and heuristic use. Reason 2, as Hughes showed in her paper surveying medical students,
Okay.
there is still a long-standing, it's getting rowdy out
What
there.
is going on out there?
There's a
Holy man.
long-standing, as Remle alluded to, misbelief that race is a biological construct. When Hughes asked medical students in first year and second year studies some proven false understanding about the biological concept of race, things like black skin is thicker, somebody who's black, their blood coagulates faster, they have more muscle mass.
Don't feel pain the
very
same.
large percentage of medical students said, yes, these things are true. These things are all proven false. There's
So
no
let me dig into this, 'cause
biological
I'm a-
construct of this.
So here is where this is not my field,
Yep.
right? I am open-minded to the fact that it certainly seems that this is happening. I don't know why. I do know. So, I'm from East Texas. I do know some overt racist. They're a minority of the people.
Yep.
But when I hear things like race is not a biological construct, where I go with that is the amount of melanin in your skin is genetically controlled. Now, it's environmentally controlled too, but that's a genetic characteristic. That sounds like a biological construct.
Yeah, so great topic. So let's take the spectrum of melanin in skin,
Okay.
right? Where we draw those lines as a society to say, this is black, this is Hispanic, this little yellowness is Asian,
Yeah.
that's a social construct.
Oh, this reminds me of a podcast we shot in Mexico, where we were talking about pulse oximetry.
Yes.
Oh,
Interesting. So,
And importantly, sorry, just one more point.
Yeah, yeah.
Importantly, those things change over time as our society changes over time. So where those
cubby
lines
hole.
are drawn. So people that were considered Irish or Italian at once were not considered white.
Interesting.
Now they are. So it's evidence that we're making this shit up.
Yeah.
It has tremendous biological consequences, which is where some of the confusion comes, where things like sickle cell disease, right? We tend to incorrectly think that that's a biological available option for Black patients only. That is not true.
I have learned this. It is a Mediterranean issue.
That's right. That's right. That's right.
Turns out there are two sides of the Mediterranean.
That's right. And largely this is environmental, as you spoke about, right? Folks that have a lot of melanin came from the equator, where it was a protective
turns out there's a lot of malaria.
That's right.
Cystic fibrosis, the same thing. I was taking care as a medical student of a 13, 14-year-old, very, very dark-skinned patient. And I asked, what's going on? Tell me about your medical history. And they said, I have CF. My little brain, I know CF is cystic fibrosis. Only white people have cystic fibrosis. And I looked at him, and this poor kid clearly has lived through this before, and was very generous and said, no, Black people get cystic fibrosis too. And then proceeded to teach me about cystic fibrosis. I'm like, well, no shit. Thank you very much.
Right. So this gets complicated, and the directionality gets confused, which adds to the confusion around the biological, which is called scientific racism. This belief that there is a physiological difference between people. It gets confused on things like hypertension and the African American population.
Clearly.
Right?
Yeah.
The directionality here is really important in that racism and the stressors of society cause hypertension. There's not a Black gene that makes you more susceptible to hypertension.
Now, we do know that there is a connection between dietary habits and hypertension. For example, if you manage to reach my age and you really enjoy salty foods, your blood pressure goes up. And I'm not familiar with the research, but my guess is that there is certainly when I was interviewing for residency in South Carolina, where they like their salty foods, where they also have a large African-American population, they said there are lots and lots of hypertensive patients down here.
Yep.
Interesting.
Yep.
There's also this notion of food desert. If I don't have transportation and I live in a neighborhood where there's no grocery store, but there's only a convenience store.
Or lots of fast food chains.
Yeah, and which one's cheaper, going to farmer's market and getting fresh fruit or a bag of potato chips? So these things collectively are social determinants.
So heavily influenced by socioeconomic status.
That's right.
Absolutely.
That's right.
Interesting. So when you hear something, and this is something that is likely to be an activator, if you will. So you hear this and you get triggered. And the classic thing is you hear race is not a biologic construct, and you think that is bullshit. And I have to tell you, that was my initial concept too. But what you're essentially saying is yes, the amount of melanin in your skin is biologically influenced.
I would say it's even environmentally influenced.
Oh, clearly, just sun exposure and age and lots of other things.
That environment has changed biology over time. So it's not as if someone is
And that's called evolution.
born. That's right. But it's not as if, you can tell if I'm Black by doing a genetic test.
No, I guess where I was going with that is because everybody knows it's your blood type. Where I was going with that is that is just one character. It's the whole genotype phenotype thing. But that's not what you're arguing.
Correct.
You're saying the social construct is the meaning we attach to it and the categories. We're taking a continuous variable and making it dichotomous.
Correct.
And the buckets or the bins that we're putting people in is 100% arbitrary.
Correct. And to further confuse it, those bins have biological consequences, right? Which then feeds into this confusion, I think, right? So when we think about explicit and implicit bias, one of the challenges that I have with that narrative, if you will, is that if I believe Black people are physiologically different and that influences my treatment of them, that's explicit bias. It's not because you're broken or you're racist, but your training has informed you that different people are different physiologically, and it's just incorrect.
Well, I will tell you, I was trained in medical school. When I see an African-American male with hypertension, I start him on an ACE inhibitor. and I start a Caucasian on a calcium channel blocker or a beta blocker. Diuretics, nope. We start off our African Americans who have failed ACE inhibitors. There was a whole algorithm, and it was based on race. And it's interesting, you bucket, say you have 34% melanin, and you're saying the treatment is 100% different than if you have 34.7%, which, when you say it like that, it's complete crap.
That's right.
So fascinating stuff. All right, so I think we could, this is a fascinating discussion, and one of the reasons I wanted to have y'all on is because we're here together at the outstanding ESO PCRF Research Forum. Felt like I needed to plug it again. And but the other reason is that EMS, the comments from that EMS world.
EMS1.
EMS, excuse me. Sorry about that, y'all. Two distinct things. Both have wonderful characteristics, but they let you comment. And the comments I was reading were disturbing to me, not because of the people making them, because I don't think they were bad people, but I don't think they understood what y'all were saying. So I wanted to have you on. The biologic construct is fascinating to me because I don't think I understood that. But I wanted to talk about what if. So we're not saying that this is, you are doing this because you don't like black people. We are saying by definition, there's a bias, right? Much like we say discrimination is bad, but every test you have ever written is designed to discriminate. All that means is you're treating one group differently than another. You may treat them differently because they don't know this material, in which case nobody has a problem with that, unless they were the ones that didn't know the material. But that doesn't necessarily mean you're making a conscious decision because of the color of their skin. So I know that you can't explain, because you don't have data to support this, why that distinction, why there is that bias, the difference. But what are, say, your top 5 guesses, if you will? Clearly, you study this a lot. So I think these are probably more than pull it out of your ass guesses. I would say these are pretty well informed from a subject matter expert. Why do you think this is happening?
Why the bias exists?
Correct.
So I think many of the reasons are what we've talked about so far. Mm-hmm. Stereotypes, we have to use stereotypes in our business. They are super important. However, they come with baggage, and we tend to underappreciate the baggage they come with.
Almost like there was a book about this.
Almost like a book. Mm-hmm. Number 2 is we have false information about race as a biological construct. And so if we are wandering around treating patients and we think some patients are physiologically different, and that's an incorrect belief, that may influence our care for those patients. Number 3, I think the big category is language. Most patients that don't speak English are racial minorities. Also, most patients that don't speak English are poor. So there is a triple whammy here. They're minorities, poor, and they're unable to speak the same language as the provider. Right? So that is a mechanism that creates a substandard of care for those patients. Now, I think what's important across all of these is, as said by, I need to remember her name, an author that wrote the book Running While Black, reminded us all that racism isn't the shark, but it's the sea. Meaning it's not, we've got a bunch of racists out there, but it's the soup we all live in. Right? This is important because I think often when we talk about racial disparities, we tend to put the blame on the frontline provider as they are doing something wrong. That's just happened to be a convenient place that we measure it. If we look at LHP population, which is limited English proficiency patients, which is what they're called in the literature.
LEP.
LEP, limited English proficiency. Agencies do a terrible job in supporting frontline providers to be successful with these patients. We don't provide them with quality translator services. We don't provide them with good training. We don't do CQI overview of their charts. We don't call providers in like we do if they miss a stroke or a STEMI, indicating that these patients are important to us. So providers are left to do the best they can, and they fumble through Google Translate, and they find a 6-year-old girl to talk about a vaginal bleed on mom, right? Really inappropriate things that if you were to do those things in your hospital, right? Completely frowned upon. You need a qualified medical interpreter, right? You would never do that, right? But we allow
Happens
it
every day in the
That's
hospital.
right. We allow our EMS providers to treat LHP patients
Yeah.
however they want because we don't provide resources. So I bring this example up because this is not a provider deficiency. This is a structural agency deficiency, that the agencies aren't providing the tools and the resources and the motivation to do the right thing, right?
I'm so glad we had you on.
Oh, good.
You know, we've met only a couple of times, and Remle has already told me a couple of times, you got to talk to this guy. He's a rock star. You proved it right. Once again, Remle is right. Fascinating discussion. I'm going to have to limit it because honestly, I don't think I charged my batteries all that well. So I think we're about to, not that we've ever had a podcast that just turns off.
Yeah.
At least I did the last time we were recording one here. I don't think I actually
Across the hall.
Right. Hit record on one. So one thing that I am curious about, one question I have that I don't think was answered is that differentiation, that differential between treating pain medicine and not, between whites and blacks, is that influenced by the self-described race of the clinician?
Right, right. So it's a great question. And I think I want to try to briefly paraphrase the importance of it because the industry in the racial disparities DEI work in medicine has for far too long been, in terms that my wife and I use, pondering the problem. And we just constantly ponder the problem. Like, here's a disparity, here's a disparity, here's a disparity. And
Woe is us.
yeah, we need to move to, let's fix the frickin' thing. Let's move to interventions. Let's move to finding ways, testing things to mitigate the disparity instead of just saying, oh, that's
Look at all these.
That's right. That's right. So
Bring some PDSA cycles to this
yes,
shit.
exactly, exactly. So I say that because there's some literature in other areas of medicine. The history around concordance between the race of the provider and the race of the patient in other areas of medicine have not yet sufficiently explored. Does that make a difference in the quality of patient care and the outcome? There's a big body of literature that talks a lot about it greatly improves the satisfaction of care.
My helper looks like me.
Right.
Yeah,
Which is important.
All right.
If there's concordance, the satisfaction goes up. Lately, there's been a great paper that talks about when there is concordance on OB emergencies around births, infant mortality improves when a black mom has a black OB-GYN at the birth.
That's both exciting and sad.
At the birth, exactly. So it brings up a lot of questions.
Yeah.
Right?
Well, what about with EMS and pain medication?
So short answer is it's never been explored.
Okay.
The other short answer is we explored it 2 days ago and we presented it today.
You did.
There's lots of data challenges around this question because we don't often have HR level data. And when we have HR level data, HR often doesn't collect race.
Yeah.
Right? It's often it's not a required field, right? Your HR doesn't say, welcome aboard, what's your race?
Right.
And if they did, you might say, I don't think I want to work here.
That's right. That's right. So we have very limited data. However, the
I
ESO...
answered that question. So I got that.
Good.
And it's always a voluntary question.
Yep.
But I don't think we have a good understanding of, well, why might they be asking me that question? Our gut reaction is, oh, how dare they?
Yeah, well, I'm a nerd, and I know anybody asking me a question is likely to analyze it, so sure, I'll give you the information. I think I'm a little unusual, though.
Yeah.
Just a little?
So, I guess the Dave Page, who runs the PCRF, was rather clear with us that we were not allowed to discuss the results of any of the things that have been done here, so we will honor Dave's wishes. But I do want to point out that you're not done with this paper. Right. This is a question you're aware of, you want to know, and you are working actively, even with this data set, to answer that question.
That's right. And this data set in particular is awesome in that because it's really large.
Yeah.
And so it provides a sufficient N to look at sometimes the really small effects that you might see from race.
Yeah. Really interesting topic. Thank you so much for being on. Remle, I want to plug what is opening up tomorrow.
which won't be tomorrow when this goes out. Probably.
Right.
Fair point.
Exactly.
It's probably
So,
already open.
September 15th.
Applications for the next ESO Pre-Hospital Care Research Forum collaboration on a research forum here at ESO will open. Those are available on the ESO website. It's a great place to find them. Twitter, LinkedIn, it'll be all over the place.
Awesome. You're listening to this podcast, therefore you are a nerd. Please, if you're interested, this is a wonderful, wonderful thing. I was just talking to like 4 different paramedics in this event today who are saying this is like life-changing. I know that I want to do something, but I've been sort of struggling and not knowing where to go. All I can find are podcasts. This is a great way to get involved. Please check that out. The last thing I want to say is we are doing a lot of work with this data set, and this data set is only as good as the data you put in it. Please understand that when you document, what you document matters. It is incredibly important. It is driving our profession. Please take an extra 30 seconds and think about what you're documenting. Guys, as always, thank you all very much for listening, and take care.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.